Hello, welcome to Wellness Wednesday in the Yoga for Migraine Facebook group. My name is Adrienne Delorco, and every week at 2 p.m. Eastern, we bring you expert interviews, wellness talks, and yoga classes for the migraine community. I am thrilled today to talk about medication adaptation headache with Dr. Donna Ionel. She is a friend that we connected at Headache on the Hill this year in DC, and she was gracious enough to share her expertise today here. But also, I was really grateful to her when we were advocating with Congress. She would attend our meetings, even if she didn't need to. For our state, we were in different states. She would come share her expertise and her experience as a headache specialist. So let me talk all about Donna, and then we'll dive in. So Dr. Donna Ionel is an assistant professor at the academic hospital and a headache neurologist. She completed her med school at Kansas City University of Medicine and Biosciences and followed her neurology residency and headache fellowship at the University of Kentucky. She is passionate about headache advocacy and improving the lives of those with migraine and headache disorders. She was a participant in the Patalucci Advocacy Leadership Forum through the American Academy of Neurology and was a participant in Headache on the Hill, where I got to meet her this year. And when she's not helping clients and patients, she enjoys cross-stitching, playing board games with her friends, and spending time with her family. So Dr. Donna Ionel, thank you so much for being here and talking today about medication adaptation headache.
Yes, this is a great topic because medication adaptation headache, which can also be called medication overuse headache or rebound headache, or some other names that you might hear it called, is actually the cause of chronic headaches in about half of people. So it is really, really important to talk about and really important to identify and treat.
Wow, I didn't realize, how prevalent that was. So you gave some of the other names. I think kind of old school name is rebound. And some of the terminology has changed because we trying to move from like blaming the patient, like we are overusing it, or that this is something that just happens over time. And maybe you can explain maybe the science behind what happens here.
Yeah. So again, I do think that the language we use is very important. What I do want to let people know, though, is that if your doctor calls it medication overuse headache, that's still the technical, like medical diagnostic term. So while I do think that a lot of times in the medical world, migraine patients do kind of get blamed for things, and there is a stigma. Just keep in mind your doctor might not be saying it maliciously, but because it is the technical diagnostic term. But medication adaptation headache is basically a type of headache that you can only have if you already have an underlying headache disorder. So that means that if you don't live with migraine, don't live with tension type headache, or some other headache disorder, you can't give yourself headache by taking too much pain medicine. You have to already be predisposed to a headache disorder, already have a headache disorder. And then sometimes when we take too much pain medicine of various kinds, which we'll kind of get to in a little bit, you can actually get worsening of your underlying headaches. And the reason why nobody knows fully, which unfortunately is the case with a lot of things in migraine and headache, is that we don't fully know. But some of the ideas that we have are mostly centered around our pain receptors. So what happens is our pain receptors kind of get saturated and blocked off by medicines, and then our body kind of reacts by creating more pain to build up more receptors for those medicines to bind to. But the problem then is, again, the medicines have already bound, and now we have all this pain, and more pain medicine just kind of perpetuates that cycle. And so there is a scientific reason for it, but it's also hard to treat for that reason, because if you're in so much pain, you wouldn't be taking so much pain medicine. So it's really a vicious cycle where the underlying disorder is not well treated. So the migraine is out of control, the tension type headaches, whatever they are out of control. So we take more pain medicine because we need to function. And then when we take more pain medicine, our brain is like, hold on a minute. All my receptors are full up. I got to make more pain. And then you make more and more pain, and it just goes over and over again.
Yeah, one of the more frustrating aspects of living with migraine, where the medication that we have that can make us functional can ultimately like exacerbate it over time. So which meds are the ones that can exacerbate medication adaptation headache?
So all of them, all of
Oh
them.
boy.
So now I let me come back and say something. So here's what it comes down to, though, is that it comes down to how many days per month you're taking them. So the medicine that causes the most risk of medication adaptation headache are medicines that contain butalbital. So those are kind of the ones that are kind of at the top of the list, that very few doses of those can cause really bad adaptation. After that are opioids. That's the second most common. And then beneath that, I would say everything's probably about the same, like your triptans versus your NSAIDs or something else. I would say, I don't know that one causes it more than another. But again, what it all comes down to is how many days per month. So
can I interrupt for one question?
Please.
Do the newer anti-CGRP acute meds fall into this as well?
I was coming to that. Adrian,
okay, well,
beat me to it.
Beat you to it.
So I am gonna.
I'll let you explain
that.
Let
me give my spiel. I'm hyped up. Let me give my spiel. So again, it all depends on how many days per month you're taking it. So most of the time, if it's prescription, so if it's a triptan, if it's DHE, if it is a combination pill like an I don't want to use brand names, but something like an aspirin, Tylenol, caffeine combination pill, opioids or butalbital products. Those, if you use them more than 10 days per month, on average over 3 months, so 10 days per month, we'll just make it easy. That is when you get the risk of overuse. And then medicines that are kind of over the counter or are considered simple analgesics, meaning it's not a combination pill, so not more than one component. So things like ibuprofen, acetaminophen, sometimes even prescription strength of that form, but again, it's not a combination. Those are 15 days per month. So it depends on what you're taking, but I would say that I'd venture to say that most of our migraine folks are on something prescription strength. So a good rule of thumb to remember is the 10 days per month. And that's why a lot of times doctors will say, don't take your pain medicine or your rescue medicine more than 2 days per week, because 2 days per week will land you at 8 days per month, and then you're underneath that limit.
Okay.
Now was that
question? Wait, one more. Was that all that what you described, like the 15 max? Was that only for over the counter, or like a triptan? That's like a single thing,
those fall into the 10 days. 10. So triptans fall into the 10 days. Yep. So most of the things you can get by prescription. So triptans, DHE, opioids, butalbital containing products,
that's the 10.
Are 10 days. Yep. And then things from over the counter are 15 days. But now keep this in mind. If you are taking on separate days, both a triptan, maybe you take a triptan on a Monday, and then you take an ibuprofen on a Wednesday by itself. Because you're on a triptan, your limit is still 10 days per month. So you don't get to take one of each, because then you'll end up with 25 days, and then we're in trouble. So whichever one is lowest, that's what you should stick to.
Okay.
Now, to come back to your question about the G-PANTs and the ditans as well. So we only have one ditan right now, lasmiditan. And then for the G-PANTs or the CGRP inhibitors, we have ubrogepant and rimegepant and zavegepant too, newly.
That's a mouthful.
Yes, that's the nasal spray one. That's how I always, whenever people are like, what did you say? I'm like, it's a nasal spray. So the zavegepant, the G-PANTs especially, as the first one came out in 2019. And since then, We have not had any studies show that they can cause medication overuse now, or medication adaptation headache. Now, what I will say, what the caveat is do they actually not cause it, or have we just not studied it because they haven't been out for long enough? That's the part I don't. So I think, and it's the same with the lasmiditan. So I think a good rule of thumb, since you only get 8 or 10 uses a month anyway, is to try to stick to that, because it might be that our research just hasn't caught up yet because the medicines are new, and in another few years we'll find out that they can cause medication adaptation too.
Okay. Yeah, that's really interesting, because I feel like they have thus far been marketed as like they don't contribute to this and like, hey, this is a great alternative. So, but yeah, I can understand
We don't think, but we don't know.
New. Yeah, got it.
It's a big debate, so we still don't know.
Okay, so where to go from here? So how do you know if you are experiencing medication overuse and it's not just chronic migraine or something else?
So I think that part is a hard question to answer, because sometimes you don't. So sometimes you, again, it's a chicken and an egg situation. Did you already have chronic migraine and that's why now you're using pain medicine 20 days per month? Or did you have episodic migraine, but maybe it was at a high frequency? So maybe you were having 8 attacks per month, but then you have milder headaches in between. So you started taking more than 10 days per month of prescriptions, and then we got into a bad cycle. I don't know that there's any way for someone to really know. And so when we get into this situation where we are not sure, like, is our migraine just really poorly controlled? Are we kind of doing this to ourselves? A good solution is considering starting a migraine preventative, because there's a few schools of thought. So some folks or some providers will recommend doing a washout period where you don't take any of your pain medicines for 6 weeks and then see kind of what your body does. That can be really hard for people. If you have a job, if you have kids, you have a lot of pain, it can be really hard to take nothing. Yeah. And what the research kind of favors and what the guideline really is, or kind of what most headache specialists agree on, is that it is good to do some type of a washout, whether it's a total washout or whether we just say, starting today, no more than 2 days per week. But we don't do that all on its own. We have to start a migraine preventative to help the body, because if you just cut the pain medicine completely, 2 months later, you might be like, well, I'm still having 20 days per month. So it wasn't the medicine. And now what? And we've spent 2 months. So a lot of times what we'll do is we'll suggest starting a migraine preventative, and at the same time, cutting back on the pain medicine. So then basically the preventative will drop the number of attacks, which will also drop how often you need the pain medicine.
Yeah.
I don't know that anybody at home, and sometimes even a provider, I don't know that we ever fully know, is it all medication overuse or is it chronic migraine?
Yeah. So the symptoms are pretty similar. There's not like qualitatively, oh, this is a medication overuse style symptom that would be different.
No, unfortunately, it's your typical attacks, just more frequent.
Okay. Yeah. So yeah, it's not like not more like a tension headache. It is just pretty much you're just getting them more often.
Not usually.
Yeah. And kind of on that train of thought, we did have a question from Kathleen. What can people expect if they are trying to pull back the number of like over-the-counter meds, for example? Like, what do people experience during this detox or withdrawal period? How to get through it? It sounds like you're advocating less of a cold turkey approach and more of reducing it slowly.
Yeah. So I personally recommend a preventative at the same time that I say, let's try really, really hard, no more than 2 times per week, 2 to 3 times per week, while we wait for the preventative to kick in. But what I usually counsel people on, so if there's a medical reason why somebody would need to cut medicines cold turkey, like let's say our kidneys are being affected, our liver is being affected, something else is going on where I'm like, we have got to pump the brakes today. What I usually counsel people is that if we're cutting cold turkey, again, for about the 6 weeks is the usual recommended, the first
Sounds
2 weeks.
brutal.
Yeah, the first, well, and I was just about to say it is brutal. So I always tell
Yeah.
people the first 2 weeks are the absolute worst because now your body is used to pain medicine. Again, not
Mm-hmm.
because you're addicted,
Yeah.
but the body is used to having that medicine there, saturating
Mm-hmm.
those receptors. So the body goes a little bit haywire. So usually in the first 2 weeks, you can expect a lot more intense headaches, a lot more frequent headaches, and then slowly it'll start to taper off where it's less
Mm,
frequent. But
got
usually the
it.
first few weeks are the worst.
Yeah.
But sometimes
Uh,
it's necessary evil.
yeah.
Again, we don't want to hurt our other organs.
So, with some of this like idea of especially if someone is high episodic, chronic, I think what people really get hung up on this kind of quandary where we're like, okay, maybe you've already used your two, or people start trying to not take their medication because they want to avoid the medication adaptation, but yet maybe they're waiting too long, or then like they end up having more symptoms. So how do we find this middle ground of treatment where we're not like always holding off too long, or maybe taking too many? And
Yeah.
I think it's a very, very common and difficult place for many patients with migraine.
And I hate to keep harping on this, but the truth is that it really all comes back to your preventative. So, the migraine diary is very, very important because it, again, will show you how often are you actually having the attacks. We know that the earlier that you treat, the shorter the attack will be. So it's usually, it is very difficult, certainly, if it's already been 2 days that month to say, or 2 days that week, I'm sorry, to
Mm-hmm.
say, I can't
Yeah.
take something now because I'm gonna overuse. But I think again it comes back down
Mm-hmm.
to if you're needing it 2 times per or 2 or more times per week, that means you're having more than 8 attacks per month, and that's a lot. And so
Mm-hmm. Mm-hmm.
think I lost you for a second. Are you still there?
Oh, I
Oh,
still hear you. Yes,
okay.
I still see you at least.
We had a little internet glitch. So sorry for all the people watching this, like what the heck just happened on my end. There's a little internet glitch. So that's the tricky thing. The way to always, always, always think about medication adaptation is, is this happening because my frequency is too high? So I
Mm-hmm.
usually don't recommend waiting. I still think that as early
Mm-hmm.
as you feel a migraine attack, you should take something. And if you're like blowing through all of your tablets in the first 2 weeks, 3 weeks, and then you're
Mm-hmm.
needing to reach for ibuprofen or something else, um,
Mm-hmm.
yes, it would be best to not reach for something else. But if you are, again, it means that your preventative might not be working well for you.
Mm-hmm. I- Um, is it okay if there are periods in our lives where maybe we do need a little bit more? For example, menstrual migraine, or we talked about seasonal allergies, where
Yeah.
maybe I know you mentioned that really the effect is like after 3 months, that's when we start to have it. But, for something like a lot of people with menstrual migraine, they are recommended to take a triptan every day that week or something. How does
Correct.
that work?
Yep. So again, you have to look at the average of over kind of 3 months. And if it is something where it's like purely menstrual, where you have to take a triptan, leading up to the cycle and then for however many days in your cycle. Again, the way to look at that is if it's the 5 days per month that you have your cycle or something else,
Mhm.
and then you're however long, and then you're having 1 or 2 attacks the rest of the month might not be, you
Mhm.
know, something to worry about. So
Yeah.
again, it's all about the average. But
Mhm.
again, to keep harping on it, if you do have menstrual migraine and then the number of attacks you have outside of your menstrual period is still high,
Mhm.
you might still need a preventative.
Sure.
So
And I imagine most people, that are listening to this, most people have chronic migraine. They've kind of gone through the gamut, like they have probably preventative or they've tried a bunch. So yeah, how do you work with people like that where kind of they've felt like they've tried all the things and And maybe their acute thing is like the only thing that helps them just function. Or
So, of course, that's a hard question because at one point there are a lot of medicines that we've kind of used and we don't have a ton of options, but something that we're looking or that the headache world is looking more into is combination therapy. So,
okay.
like being on multiple types of preventatives that maybe have not been used in combination before that have mechanisms that work well together. So, one example that's become kind of popular to study is the combination of a CGRP inhibitor, so like the monthly injectables or like the pills with onabotulinum injections. And so, and the reason why is that they act on the same receptor, but at different parts of the cycle. So sometimes using them together works really well, or sometimes even using onabotulinum toxin injections plus an oral preventative like topiramate or amitriptyline or something else that we've used in the past. Because I think sometimes we end up like that we don't always stack. We're like, okay, well, this didn't work, so let's stop it and let's start a new one. And sometimes we end up on monotherapy, and sometimes that's just not enough for people. Some people can't get away with just one medicine at a time. So it's a hard question to answer because it's so patient dependent. But I would say if there's a lot of people that feel like they've really tried everything, my question would always be, have we tried a combination therapy? And then again, the key with medication adaptation is the pattern over time. If it's, 1 month, you need your pain medicine 12 days instead of 10, okay. As long as it's not every month, every time. And there's also lots of other things. So non-medicine things, which I know aren't always feasible for people, but other options like doing biofeedback, which is a special type of cognitive behavioral therapy that a psychologist can do. There's the neuromodulation devices. Adrian, I know you love your Cephally device. So Cephally's one. We actually have 5 FDA cleared neuromodulation devices now. The most recent one came out in 2021. So there's the devices, there's acupuncture, like yoga, tai chi. There's really a lot of things to stack on top of your medicine that can maybe help. Again, instead of trying 1 or 2 things in isolation, doing a combination of things.
Yeah, I think that's a great recommendation. And I'm really glad to see, I think, more neurologists going in that direction where it's not just one at a time. You fail one thing and really let's put it all together. And I would love to hear you clarify, is the medication adaptation headache, is that most affected by the days, or like, let's say you take 3 pills in one day? Does that just count as, one risk day? How does it work?
It does. So it is by days. So if you have to repeat your triptan, so the difference is what we call doses versus days. So if on one day you have to take 2 doses of your triptan, that still counts as 1 day. So obviously you might run out of your medicine faster, but it still counts as 1 day. So let's say that you get 9 tablets of your triptan. You always have to repeat them. So after 4 days, you are completely out of your medicine. You still have 6 days that you could take ibuprofen or something else, again, that your doctor has told you to take. So please, nobody go and be like, this doctor online said it was fine. Please always tell your doctor what you're doing. But it is by days, not by amount of pills.
Okay. Yeah, I think that's an important distinction so that people, if they have a really bad attack, just treat it hard, all in one day, doesn't increase your risk. So that's important to know. I have a question here from Sarah. If you are overusing a drug that's effective, that may be causing rebound, but maybe replacing it with another drug with less efficacy, but then you got to use it more, is that helpful? And I kind of feel a little bit similar, like, for me, triptans do work really well, but then I kind of started more Ubrelvy, and sometimes it's, it works and sometimes it doesn't, but maybe if I'm using more of that, do you have any insight on how these things balance out in the end?
So is the question about
like maybe
no,
I
go
think
ahead.
It's like if you have one medication that maybe helps but maybe has a higher risk of medication adaptation, you're taking less of those, but taking something maybe with less risk, but you're actually kind of end up needing more of them.
Okay, so I will say that this is something that I do see often with opioids or butalbital. And
Okay.
what I want to emphasize here too is that sometimes there is a time and place for those medicines. So I am not here to say that if your doctor has put you on one of those, it was the wrong thing to do. So I don't want anybody here to think that, because sometimes people do need to be on those. And again, migraine is very, very person dependent. But let's say your doctor has decided, hey, that opioid that you were getting, like, I think it's causing really bad, medication adaptation. We got to get rid of it. We got to replace it with something else. I do think that a lot of times we do go to something that might be less effective for the patient because, again, because you're all going to get sick of me, it comes back to the preventative. Because sometimes if you ramp up the preventative, the body's able to respond much better to medicines that weren't effective before.
Good
So
point.
sometimes, again, treating the underlying disease makes medicines that maybe didn't used to work that well for you start to work that well for you. Because again, it's all about those receptors and how they're getting saturated.
Okay, thank you. This is a topic I think about a lot. Is powering through symptoms and rationing our acute meds helpful, or can that be counterproductive? You know what I mean? When people are just like, oh, I'm not going to take it. It's not a really bad headache yet. But is also powering through can also reinforce the migraine. Like, we can't win.
I think powering through is rarely the answer, because the other way to think about it is not just if you power through, your pain's gonna, might be worse because we waited too long. The other way to think about it is that if your pain is worse, it also might last more days. And then you run the risk of going into status migrainosis, which is a migraine attack lasting more than 3 days in a row or 72 hours. So sometimes if you don't treat early, because you're like, well, I've only got one pill left, I got to make it last till the end of the month or something, you might actually be doing something counterproductive or hurting yourself, because if you don't take it and then you end up with a migraine attack that nothing touches, you might end up in the ER, you might end up getting admitted to the hospital. So oftentimes it is counterproductive to hold off. And again, it comes back to if you're blowing through all the tablets really quickly, we got to change things up.
Yeah, it sounds like really trying to find a preventative strategy is the first foundation, whether that's with medication, devices, lifestyle, like getting that long-term stable, and then hopefully just trying to reduce that need for the migraine pills. Got one more question, maybe one or two. Pam asked, if you are taking pain meds for another health condition, how does that interact with migraine and medication adaptation, and how do people manage something like that?
So this is a hard question. And what I'll say is oftentimes if you need daily pain medicine for a different type of pain condition, most of the time we're not going to say, no, you can't take that anymore. It's giving you medication adaptation. Most of the time what we'll say is, okay, that's your pain medicine for your, blank pain problem, for this pain problem. Do not take your migraine medicine also, more than the recommended times per month. So normally it's hard because it might be true that if you're on chronic pain medicine, it may potentially contribute to chronic migraine, but taking away the chronic pain medicine for a different body complaint is usually not the answer, because we know that migraine and chronic pain kind of go hand in hand. And if you're not treating one, the other one's going to flare up and vice versa. So normally it's about working with what conditions we have, rather than it being such a hard, like, end all be all, like, no pain medicine, only 10 days per month, like absolutely nothing else. It's usually not so black and white. Because again, we don't want to exacerbate a different pain problem. We just want to be careful how often we're reaching for stuff for headaches specifically.
Okay, thank you. So from your experience working with migraine patients, and maybe specifically with people with chronic migraine, for example, do you feel like the risk is worse that people are underusing their medication because they're worried about rationing and worried about medication adaptation, or more the other way, that they're overusing it and then that's creating more of this? Or can you tell? Because I think there's just,
That's
there's
such a hard question.
yeah, I think people feel that push and pull on both ends, and it's hard every day, making a decision about, do I take my med or not, and when, and which one, and is it going to make it worse in the long run, right?
Yeah, that's such a hard question because we know that undertreating attacks leads to things like absenteeism or presenteeism, which basically is you're either not going to work because of pain, or you're at work and your function is way low, like you're basically functioning at 30% instead of at 100%. So I would say those are high risks if you underdose. And then if you overdose, so if you take too much, you run the risk of medication overuse. I really don't know that I can pick which one. I think it's such a hard question, Adrian. Or whoever asked it. Why did you do that to me?
Oh, that was me. That was me.
Okay, that one was you. So you get all the blame. I would say with chronic migraine, specifically, the medication overuse may be the worst way to go, because we know that we already know we have a high burden of headaches. And so if we also overuse, it might be hard overuse, or again, have medication adaptation, might be harder to play catch up than to underuse and just hit it a little bit harder with our preventative plan. And I do want to go back and say, I've been saying preventative medicine this whole time, and I do want to emphasize that your preventative migraine care is a whole plan. So lifestyle adjustments, things like yoga, or again, Tai Chi, acupuncture, other things, plus or minus a medicine based on what your provider says. So I do want to emphasize that too, that when I say preventative medicine, I mean your preventative.
Yeah, it's kind of that multi-layered approach. Yeah.
I think with chronic migraine specifically, I would be more wary of overuse. But that being said, I just hate for someone to also get disabled by day-long attacks. So a hard question to answer, and a hard thing for patients to navigate.
Yeah, because I also hear, right, if you're not treating it, your pain gets worse.
Correct.
This is also not beneficial long-term for migraine, that like your neural pathways are just kind of emphasizing this over and over again. And
we have a word for
this.
So it's actually called sensitization, or central sensitization. Central meaning your central nervous system, which is our brain and our spinal cord. And basically what the theory is that your brain is so used to living in pain that any little hit actually makes your pain way worse. And so a lot of times this is kind of unrelated, but I think it's an important side note, is that I hear a lot of my migraine patients say, well, I'm so used to living in pain that I have such a high threshold. But actually the opposite is true. So the more used to pain that you are, the lower your threshold, and any little hit can trigger you into a migraine attack that maybe wouldn't have been so dramatic if we had been or so painful if we had been treating the pain a little bit better to start with. And it can even be the same with body pain. Like you have chronic migraine, but then you stub your toe, something, and it feels like the worst pain you've ever had. Whereas maybe if your brain wasn't so used to constantly being hit by pain, that stub toe, you would have been like, ouch, and then moved on.
Yeah, that's a great point.
It really is very tricky to power through.
Yeah. All right. One final, I'll give you a little one, hopefully not too hard this time. Let's say you wake up with a mild headache. Should you treat it with something that is more like, for example, I'll just give you my example. Okay. If I wake up with a mild headache, should I like reach for the triptan, which maybe has a higher efficacy for me, but higher risk of the medication overuse, or maybe reach for my Ubrelvy or my naproxen, which maybe has a lower risk, but maybe might not knock it out, and then I still have to take a trip down later.
So here's the hard part about waking up with a migraine attack is you don't know when it started. So it could have started right when you woke up. It could have started 6 hours ago while you were sleeping. So it can be the case that no matter which pain medicine you take, none of them potentially work as well because we don't actually know how long the attack has been going on for. I would say if you have your typical most effective medicine available, you try that. Just because the chances of knocking it out faster are higher. If you don't, you could try taking one of your less effective ones to help, but just know that it's a possibility that none of them could work because waking up with a migraine attack is difficult.
Yeah, that's a good point. Yeah, personally, I found, when my pain is more acute, like definitely I'm gonna go for the triptan. If it's still kind of like maybe tolerable, the CG or my Ubrelvy can help sometimes, right? So sometimes just the meds and the timing of maybe when you notice the symptoms or how intense that can affect which med you reach for.
Yeah, definitely.
Well, Donna, this has been very enlightening. I think the overall message in treating medication or preventing medication adaptation headache really is prevention. And it is complicated. There's not an easy way to figure out which med and when, and there is no easy answer with migraine. And just to be open and honest with that, but let's take it a step back, try to do all we can to prevent and hopefully make this less of a risk for everybody. So thank you so much for sharing, Donna, and we really appreciate you helping all the migraine patients out there live better with migraine.
Thank you again for having me. And my parting words before I go are that remember that with medication adaptation, if your underlying pain were not so bad, you probably wouldn't be reaching for the medicine so often. So please take that stigma off of yourself or others. Don't blame yourself or others if you're needing to reach for it so often, but please tell your doctor.
Great. Thank you so much.
Thank you.